welcome to the Humans of Clinical Academia podcast. I'm Judith Johnson, and this is the show where I speak with leading clinical academics to uncover their journeys, asking why they pursue clinical work, how they ventured into research, and how they've navigated the unique challenges they have faced along the way. For decades, a fundamental question has divided the mental health field. Are mental health conditions biologically determined or shaped by our social environments and the experiences that we have? For conditions like depression and anxiety, the influence of lived experiences has long been acknowledged. However, even just 15 years ago, more severe mental health conditions were widely considered to be primarily biological in nature. My guest today entered this field when the debate was just beginning to gain momentum. She disrupted conventional thinking when her research revealed that our early relationships with our caregivers, known as attachment, contribute significantly to schizophrenia symptoms in adults. Since then, she's built an extraordinary career, publishing over 200 research papers and helping transform society's understanding of mental health. Professor Katherine Berry, I am really excited today to talk to you about your career, but we always start Humans of Clinical Academia with our guests' favourite drink and why they've chosen it. So tell me, what is the drink that you've chosen today?
I've chosen sparkling water because it's a drink that I find really refreshing. I don't really like much caffeine, it gives me a headache, so I don't drink coffee and I rarely drink tea. So it's just something a bit different that's refreshing.
Yeah, absolutely. So have you ever been interested in any of the like non-caffeinated hot drink versions? I'm thinking like maybe green tea or decaf tea or anything like that, or just none of it really?
None of it really. I mean, I do drink occasional tea. I might have a cup of tea a day, but I don't like a lot of it because it does give me a headache. And I haven't drunk coffee since I had my first son.
Just caffeine sensitive. Okay, so now let's have a bit of a focus on your research. So your research has touched on that contentious debate of the kind of nature versus nurture discussion in mental health. Did you realise how contentious it was going to be when you started in this area of research?
Possibly not. It was just something that came from my clinical interest because I could see that a lot of people that I was working with had got trauma histories, and that was kind of playing out in how they related to the staff teams, how they related to myself as a therapist, and in terms of understanding the symptoms. So it seemed quite logical clinically, but when you're looking at the research evidence, there was quite a backlash against implying that families in some ways cause psychosis because of during the 1960s there was that idea of the schizophrenia being generated by the mother, so it was careful about not going back to that perspective, because of course we don't want to imply that mothers or parents cause schizophrenia in any way or psychosis, so it was sensitive in that respect, but I think it was the questions that needed to be asked because it didn't seem like a purely biological condition because there were so many kind of psychosocial factors when you looked at people's histories that could interplay and lead to psychosis. But talking about trauma causing psychosis was a bit controversial at the time.
I mean, that sounds like a difficult line to walk where you're recognising the importance of those early relationships, but trying to avoid the blame. I think it's the I remember there was a name for it, like schizophrenogenic mother, was it? Yeah. How have you managed that balance between trying to get to the truth, I guess, of the importance of early relationships whilst avoiding blame?
I think it's just about recognising there's a multitude of different factors at play. Psychosis is not caused by one single thing, and that's an important message to give to people that you're working with clinically, because people are obviously sometimes searching for the cause of their problems, but also in research as well. It's just one aspect of it, and it's not to say that even if parental relationships are involved in some way, that those parents weren't parenting in the context of their own traumas and in the context of social and economic deprivation as well. So it's about understanding the multitude of different things that are at play. Yeah.
Can you tell us some of the key things that you found through your research in this area?
I guess a lot of my research is focused on the impact of early relationships on how people, and not just people with psychosis, but people in general, then relate to other people in their lives, which is the essence of attachment theory. So it's thinking in particular about how early relationship styles and coping strategies that people develop in the context of early relationships play out then in later relationships and can be maintained by kind of clinical teams and as therapists as well.
Could you give us an example of how that might play out for an individual?
So, for example, somebody's got quite an avoidant attachment pattern. They might have learned to not rely on other people because perhaps earlier caregivers weren't available. So the individual might learn that it's not worthwhile or useful to kind of elicit support from others, and they might not have developed the skills in kind of regulating their effect by using social relationships. So then in later relationships they might find it difficult to engage and develop warm kind of relationships with others and trust other people as well.
Yeah, that sounds like it must be really difficult to manage when someone has that as a attachment style. Have there been any moments of regret when you were on this path of doing this contentious research and you thought, I wish I'd chosen something easier?
I don't know about easier because it felt, and particularly it felt really important to pursue. And there was a group of people kind of talking about a similar thing within the UK. But when I tried to publish research, and a lot of the journals are American, the big journals, American psychology is very biological still, or certainly was at the time, and well, even is today. So it's harder to get things published in larger journals that weren't sort of very biological and very diagnostically driven. So I did think when I was struggling to publish stuff that that was part of the reason.
How did you overcome that? Because I know many clinical researchers now, or clinical academic researchers, I should say, who are struggling to publish because their work just doesn't quite fit with existing journals, or maybe it's ahead of its time. In the way that you were ahead of your time with this research, how did you manage it, and what advice would you have for them?
I think two things really. First of all, persistence, because as anyone knows in academia, you've got to keep persisting with things despite rejection in order to get like papers published, in order to get grants funded. So that's a really important aspect to it. But also, I suppose, support from my supervisors during my PhD and mentors subsequently in kind of how to kind of sell things or how to write the papers and in order to make the work more appealing to other people.
Maybe this is a good moment for your first image. So your first image shows a picture of tulips. Can you explain this for us?
Tulips represents the NIHR programme grant, which I've recently completed. It was called the Tulips Project, and that stood for Talk, Understanding, Listening in Inpatient Mental Health Settings. And that was all about increasing access to psychological therapy on inpatient wards. Although it's quite hard to believe if you don't work in the field, people actually have very limited access to therapy within inpatient settings. So this project was all about devising a way of delivering psychological therapy that was acceptable to service users, to inpatient staff, to carers, and then evaluating that as part of a large randomised control trial.
Wow, fantastic. What were your key findings from that project?
We're just trying to make sense of the data at the moment, the quantitative data, but the qualitative data suggests that people valued having a psychological therapist on the ward, not necessarily, well, to provide therapy with service users and help increase their understanding of why they'd ended up in hospital, but staff also really valued having the presence of a psychologist to help them understand why people might be struggling and why they might be behaving in a certain way. So people really valued as well having a psychologist that was integrated within the team, so that they were on hand to kind of offer advice and support, and not just somebody who was, saw themselves as an expert that came into the ward to see patients infrequently. It was really valuable being ward-based as well, and actually interacting with the staff and often providing emotional support to the staff as well. As somebody that's perhaps a bit independent for the regular team, obviously working an inpatient mental health wards is really stressful, like a lot of NHS work. So part of the psychologist's role was using their skills in emotional support and helping enhance sort of staff well-being.
It does seem crazy that people who are on inpatient mental health wards struggle to access therapy. You'd think that would be the best place. Yeah. What are the ways then, what are the challenges that people tend to face in accessing therapy, or that services face in trying to deliver it?
I think often that you don't have that much psychology resource on a ward. There's lots of wards that don't currently have a psychologist, either because there isn't sufficient funding or there's vacant posts because it's not necessarily the most appealing place to actually work for a psychological therapist. There's lots, I guess, jobs that might be perceived as being easier than working on an inpatient ward with people that are quite experiencing high levels of distress, and potentially quite difficult to engage in therapy compared to kind of working in a primary care setting or a private healthcare setting. So that's a challenge, getting the actual staff on there in the first place. And there's also, I guess, attitudinal barriers as well. There's often the perception that relates to the point we mentioned earlier about psychosis being a biological condition, that maybe people don't need therapy, certainly on an inpatient ward, and perhaps they need just medication and risk management, and therefore there's no place for therapy. So there's attitudinal barriers as well as kind of resource issues.
It's really interesting because I've read that the way that we do psychology today has changed very little from when Freud was doing it. And this idea of you have a once a week, 1 hour meeting with your therapist and you get better from doing that. And I suppose the setting that you're describing would require us to really rethink that as a profession, as to the frequency of therapy, the length of therapy, what it might look like. Do you think it's possible?
To rethink it, yeah, we did for the study. So we looked at individual therapy. And we had up to kind of 16 sessions with one individual person, but when we looked at what we actually delivered, it was like I think the modal number of sessions was like 1, and then the mean number of sessions was kind of 3. So it was really low number of kind of focus sessions on formulation, and we did anticipate that. Because it's, as you say, a very different way of working. We expected session lengths to be shorter as well, but we actually found that sessions were, although there was kind of a wide range, when we looked at the mean scores, it was a typical kind of 50 to 60 minute session like you get in the community, which is quite surprising really, actually. So
moving on, you were research active from an early stage in your career. I've come to understand myself that making that step from being a consumer of research, someone who reads it, someone who maybe tries to think about how it can be applied, making the move from that to being a producer of research, someone who is publishing themselves, is a hugely important step on that clinical academic career trajectory. How did you first make that shift yourself?
For me, it was doing a PhD. I did a master's course, which had a research element to it, and my clinical training also had a research element to it. But I didn't publish from those. I think I lacked confidence in being able to think I could actually, write a paper and get my knowledge, or the knowledge that I generated, out there. So a real turning point for me was getting a PhD, where I had time, I guess, to write, and mentorship in writing as well. So that was a big thing for me. And when I first qualified, I obviously started working in a full-time clinical post, and I thought, actually, I'm enjoying this now, but in terms of the future, I think I want something more to this, and I want to develop knowledge as well as implement it.
So this relates to your next picture, which shows your PhD certificate. Can you tell us a bit more about how you came to do a PhD? What were the steps that led you there?
As I say, I was working in a full-time clinical post, and I wasn't getting itchy feet just yet because I was enjoying it, but I was thinking, actually, in 10 years' time, I'll be doing the same thing, and that might not be where I want to be. So it was good to do something now while I was still, fairly young. I hadn't got a family at the time, so I thought it would be a good idea to do research alongside my clinical job. But it became apparent that actually it's quite difficult to do that without time set aside and without kind of a publication record. So I returned to my clinical psychology doctorate supervisor, Christine Barraclough, and she suggested doing a PhD, because that would be a really good opportunity to kind of kickstart a research career and develop a publication record, and that publication record would help me obviously start to develop a name in the field and help get grants in the future. So I ended up getting a MRC funded PhD studentship, which actually meant would have meant quite a substantial drop in salary because I was a full-time kind of clinical psychologist at the time. So I organised it so that I was working 2 days a week and doing the PhD 3 days a week, so that my salary was equivalent to kind of what it would have been, or just perhaps slightly less, but I wasn't losing out financially as well. And it was really nice doing the two things alongside each other, and I think it really helped me do the PhD, because not only had I already got kind of a doctorate and clinical qualifications, but I'd also got contacts in the fields and knowledge about where to go within the NHS in order to facilitate research.
That sounds fantastic in terms of a diverse portfolio of activities. Also sounds like quite a lot to balance, being in clinic, also doing your PhD. How did you manage that?
I mean, it definitely is, and I worked a lot of hours probably, in order to, to make sure I could fulfil both roles. But the roles were very complementary as well. I think compared to a typical PhD student who's kind of just come out of university, I think I had a lot of additional knowledge, from already having done the doctorate in terms of how to, study and write a thesis, but also in terms of my knowledge of the health service, and how to, get into services to actually physically do the research. So I think that really saved a lot of time. And it was really nice having that balance of clinical work, which felt very really alongside kind of academic writing and stuff. I really valued that.
You've said that publishing your first PhD paper was a career highlight. Why was it so important?
I think because at one point I felt I was never going to publish anything. It felt like it was really hard to get things published, and there was lots of like papers. I'd submitted the paper lots of times, and I'd actually wrote a systematic review before that, and I was really struggling to get that published. So I was thinking, oh, I'm never going to get a publication. So I think to finally get that one, it was a real personal achievement, and it kind of boosted me up into getting more published.
Fantastic. So as you've mentioned, before you did your PhD, you qualified and were practicing as a clinical psychologist. What was it that attracted you to clinical psychology in general as a profession?
I did a psychology degree initially because I wasn't really 100% sure what to do. I thought about maybe educational psychology because I like working with children. But as the degree went on, I really got interested in the clinical side of things. I felt it was really important that psychological knowledge was applied and not just theoretical. And I'd done some work experiences kind of in healthcare settings. So I was a carer in a home help carer going around people's houses and helping them, supporting with the activities of daily living. And I'd done some work with people with learning disabilities. And then I had a job on an acute mental health ward during one of the summer holidays as well. So that was really inspirational, I think, in terms of helping me decide that that's what I wanted to do.
Let's move on. So your next image shows the NIHR logo. Can you tell us about what this means?
I've put that on there because the NIHR funded my fellowship. So after I finished my PhD, I got a postdoctoral fellowship, and I think that was really key in kickstarting my academic career. I think I hadn't really appreciated at the time how valuable it was. I'd started a lectureship, but obviously with a lectureship comes lots of teaching commitments. So I'd applied for some a fellowship funding in order to try and buy out that teaching time, and it really gave me it was originally a 3-year fellowship, but then I had a couple of children in between, so it went down to kind of part-time, and it ended up being about 5 or 6 years because I tagged like a clinical trials fellowship on the end of it. And so it's a really great point in my career where I could just relatively independent, and I didn't have like loads of the demands that you get within academia and more sort of senior permanent positions, to really kind of focus on my research and really get lots of papers published, as well as kind of excellent sort of training opportunities.
You just threw in there that you just had a couple of children while you were doing that. I mean, you threw it in there, but that's actually massive. It's such a huge life change to go through at the same time as doing such a demanding academic fellowship. How did you balance that?
I think a lot of my career and job has been about balancing things, and I think one of the things that I really value about academic life is the flexibility. So it means that you can obviously work it around your children to a degree that it's quite difficult to do with lots of other jobs, I think. So I've always been quite fortunate that I've been able to take my children to school, not every day, but at least some of the time, and I've been able to work around my career. So I've not always worked full time. I'm at the moment, but I haven't always, so that I could pick them up and stuff, and spend time with them before bed and things. So I think the actual nature of the job really helps with the juggling as well.
I have heard it been said to me over the years that an academic career is so demanding that you need to drop something really significant. So either you need to accept you'll not have any friends, or that you won't have a family, or what was the other thing? I think it was maybe one of those two things. You have to drop one of those two things if you want to be an academic. Is that true from your perspective?
Definitely not. I don't feel I neglect my family, and I don't feel I neglect my friendships, I hope. So I think you definitely can, still have fulfilment in all of those areas.
Where do you think it's come from, that kind of saying, and I've heard it from a few different people over the years, and why do you think, I suppose, it still goes around when it's not true? What's maintaining that?
I just think the perception that you've got to work really, really hard in academia, and I think you have. I'm not shy of hard work, but that doesn't mean that you can't, do other things in your life as well. That's just, it's about making time for them, isn't it? And saying, having a cut off really, and saying I'm not, you can't do absolutely everything that you want to do, and you can't finish everything. It's about having a sense, I think, of having things that's still on the to-do list. And I think actually clinical training was really good for that, and the real sort of being first qualified in a clinical post and being comfortable with the idea that you've got things on the to-do list that you can't do immediately, and they've just got to kind of sit there. So it's sitting with that uncomfort, and I think I found that quite difficult when I was younger, because I was used to just, I suppose, managing the anxiety of having lots to do by just doing it. So being in a full-time busy clinical post was a good exposure to being able to do that without being able to do everything that you need to do right now.
So, Professor Katherine Berry, let's go back to the start. You were born in the West Midlands in the 1970s and growing up in the 80s. What was that like?
It's very different to life today. When I think about my children's life, just what they're exposed to in terms of technology was way different compared to when I was growing up. And I suppose it makes your world a bit smaller really as well. But there are some pros to that as well, in terms of, there's less exposure to things that might be potentially risky or damaging in terms of relationships. I kind of, at that time as well, it wasn't that typical to go to university. So I suppose that was something that was a bit, I suppose my own kids, there's some implicit expectation that, they will go to university and do those things. I've never said that to them explicitly, but I guess if your parents have done that, then it's that the expectation that they might. And I didn't kind of have that, but my parents very much did want me to, to go on to study, because they hadn't had that opportunity. So I think that was important in kind of giving me some incentive really to go off and do a degree.
So were you the first in your family to go to university and complete a degree? Yeah. Were there any challenges in that for you?
I don't think so, no. I think that, it wasn't that anybody stopped me in the sense, and I think my parents are very much behind that decision because they hadn't had that opportunity. And there were times when I felt like actually I don't, like perhaps when I finished my A-levels or even GCSEs, when I felt like, I don't want to study anymore, it feels quite tough. But, my parents have encouraged me to kind of continue with it, and it wasn't expensive to go to university then either, because all the fees were paid for. So I think it's obviously more of a barrier now when you've got to have financial backing or get yourself into a lot of debt. I wasn't really in that position, and at the time the accommodation stuff wasn't as extortionate as it is today. So I was quite lucky in that respect. People of my generation who had that opportunity to study without the financial burden that people have today.
It's time for your next photo. So this photo is a bit different to the others. It shows a picture of a mental health hospital. Can you tell us more about this?
Yeah, that was the first place that I worked in mental health. It was an inpatient hospital in Birmingham. It was actually a private hospital, and it's where I had a summer job. And that was really, as I said, my first exposure to mental health work. I was quite nervous about starting because I didn't quite know what to expect in terms of mental health patients, because I guess I'd had, even though I'd learnt about things on my degree course, I hadn't really had much experience of people with such severe mental health problems. I was actually quite surprised to find that people are actually really normal and like anybody else. So that was really eye-opening and a really valuable experience. There was quite a big difference between, I guess, the people that were in that hospital being a private hospital and later NHS hospitals that I worked in. But it was a really good, I suppose, exposure to what mental health work is like and how therapies and therapeutic approaches can be valuable for people.
How do you think that hospital that you experienced earlier in your career would compare even to similar private hospitals of today? Do you think they would look similar, or would there be differences?
I think there'd probably be differences because now, due to the shortage of NHS beds, a lot of NHS patients who, might have high levels of kind of substance misuse and more severe mental health problems may end up in sort of private hospitals as well. Whereas the place I was working, I guess, was there was a variety of different people there, because I remember there were some people from the NHS as well that were using or were in those beds. But I remember there were people there there was a couple there that used to like kind of come on a vacation to this kind of like hospital when things got a bit stressed. So you got people like that as well. So it's quite a mixture really. And I remember quite a big kind of eating disorder service as well, where lots of young girls were there through the issues of having eating problems. And obviously at the time I was a similar age to a lot of the people, so I think it was really valuable seeing that different side of things.
You've chosen to continue delivering psychological therapy alongside your academic career. Why is this important to you?
I think I really enjoy it, so I don't want to like lose my skills in it, and I don't want to lose like what I can gain from it in terms of, I guess, the self-interest in some respects. I mean, I haven't had a full-time kind of clinical post for quite a few years now, but what I've tried to do is to see people for individual therapy as part of research trials. So I've been involved as a therapist on a number of different trials over the years, which kind of allows me to have, really great exposure to like a new therapy that's been tested with some excellent access to supervision, but it also allows me to keep my workload manageable, so I perhaps just see a couple of people. And I'm actually accredited with the British Association of Behavioural and Cognitive Psychotherapy, so I need to see people for that too, and it kind of forces my hand a little bit.
Do you think it's easier for clinical psychologists and other psychological therapists to balance clinical work with an academic career than other healthcare professions?
I think if you do it like I do and you just have a kind of a small caseload, yes it is, and I guess that's harder for other professions to do that. But I think if you had a more substantive clinical post alongside a research career, I think that would be equally challenging for any profession. Although I think sometimes in the psychology world or the clinical psychology world, there's more recognition of the importance of research because people have done research as a significant element of their, core kind of qualification.
Do you think that then increases the chances of clinical psychologists going into research and continuing with research?
You'd think so, wouldn't you? But I haven't looked at the statistics, but I would imagine that there's relatively few, just anecdotally, psychologists that do continue within a research career.
And why do you think that is?
I think because I think lots of people go into the clinical course not really wanting to do research but having to do it. So I think there's that group of people. And then I guess there's people that, which always quite surprises me, who have a PhD already, go and do the clinical programme and then never do any research again, and they kind of just go into a full-time clinical post. And I guess they've kind of found what they feel most comfortable with and what they're most interested in. But so I guess it's about interest, but also about interest in the first place, but also maybe the clinical training course changes people's perceptions and they really value the kind of the one-to-one, they really value the kind of the clinical working over the kind of more academic side of things.
I've heard it said that it used to be easier for clinical psychologists to kind of dabble in research or develop a bit of a research career post-qualification than it is now. Yeah. Do you think that's part of the picture?
Possibly, actually, yeah. I mean, I remember when I first qualified, we used to have an afternoon a week for CPD, continued professional development, and I can't imagine that happens now. Where you could do research if you wanted to within that time, but it was very flexible in how you use that time. So in that respect, it would have been easier, I guess, to do both.
Yeah, service pressures are heavier now. Okay, this brings us to your last image, which shows a globe. Can you tell us about this?
I picked that image because I guess it represents that my fortune really in being able to travel as part of my academic career. I do really love travelling, and aside from my kind of like research, and actually the research has given me opportunities to travel and to see places that I perhaps wouldn't have been able to see otherwise. So, and it's difficult doing that having a family, and I've had to find kind of ways around it in terms of listing kind of help with childcare or taking my family with me. But I guess it's opened up opportunities that I wouldn't have had, I think, from a normal clinical post.
What are some of the best places, would you say, that you've been recently?
Recently, a couple of years ago, I went to South Korea for a conference.
Wow.
Which I took my family there as well, so that was really, we had a holiday like alongside it, so that was good. And I've been more recently to places in Europe. I've been to Poland, Spain, Italy. So it's just, you know, an opportunity to take work or to combine work and pleasure, I guess.
So if anyone is listening who is considering a clinical academic career, then they should be aware that travel can be a great perk.
Yeah.
Many clinicians find writing a struggle, but this is a struggle you have clearly conquered. Can you tell us what helps you to write?
I think I struggled, like a lot of people, to write at first, I think. You know, it's hard to kind of structure an argument. I think I had help with that as I've gone along, really, with people commenting in lots of detail on drafts of things I've written, you know, from my, you know, academic works. I think that really helped me learn to be able to write more naturally and kind of develop an argument. It's quite difficult to find time within the day to write, so what I have to do is make sure that I can block out time. If I know that I've got to write a paper, I need to block out chunks of time in order to do that, and to be quite clear and bounded about, I'm going to have to write so many words like on this topic, like now, on this particular, you know, day or half a day, and really hold myself to those deadlines and timetables, and rather than writing like lots of words that you then got to cut down. So I think it's quite good to be kind of bounded in what you write in the start, so you're not cutting out thousands of words, because papers obviously have a very strict word guidance, as do grant applications. So I think that's part of a skill as well, being able to write succinctly.
Do you have a favourite location for writing? Is there somewhere you like to be for that?
I think I find it a lot easier to write at home. And I've always found that, obviously now there's more home working since COVID, but even before that, if I was going to write anything, I'd write it at home rather than in the office, where there's lots of distractions, people like, you know, knocking on your door or wanting to speak to you, which is great and a good thing. But, you know, if you're trying to concentrate and focus on something, then I think I need kind of silence.
And do you have a favourite time of day? You say that you block out times in your diary. Is there a time of the day or a time of the week that tends to work better for you?
I think in the day rather than in the evening. I do sometimes catch up on work in the evenings, but I find it hard to write then. I think I need to be awake to be able to do it. So, and I try and vary a day of the week as well. I don't tend to stick to one sort of. I know some people like have a Thursday or a Friday or whatever, but I think given that my diary's sort of all over the place, I think to commit to that one regular day is quite difficult. So I kind of try and vary it.
Well, I think that brings us to the end of our interview today. Professor Katherine Berry, thank you so much for joining us. To our listeners, thank you so much for choosing to join us for Humans of Clinical Academia. If you are listening to this interview on Apple Podcasts or Spotify and you want to see the images that we discuss, please visit our Instagram page at Manchester_Catalys or go to YouTube at Manchester Catalys, all one word. Humans of Clinical Academia is a Manchester Catalys podcast. Manchester Catalys is a partnership between the University of Manchester and Manchester University NHS Foundation Trust, and we're grateful for their support, which has made this recording possible. I'd also like to thank my Manchester Catalys colleagues, and especially Umang Sinha for production and editing.